September.
Good morning, everyone. Rosa and I have been busily running around trying to find a rogue airway specialist who seems to have gone missing, Dan Steinfort from the Royal Melbourne Hospital Sleep and Breathing Clinic. Maybe he slept through his alarm, I don't know, but he's not here. So what I'm going to do is, he gave this lecture last year, and I've just pulled up the lecture capture on LMS, and I'll play it for you. Sorry? He's outside? Might be. Oh, okay. All right. But I did ask, just in case. I don't think that is the guy. That is not Dan. Is sleeping. I had to wake him just to check, but because I haven't met Dan before. But anyway, so I'll play you the lecture capture from last year. I don't know. I presume that because it'll be projected, the capture will be captured. But anyway, here we go. So you don't. I mean, you can watch this. This will be fun. We'll probably put it up on it. We will load it on LMS if it's not captured properly. But anyway, here goes.
Hi everyone, thanks for coming. We might make a start on the lecture today. So I'm presenting airflow limitation from bench to bedside, and this is essentially going to focus on the two commonest causes of airflow obstruction, and both sort of compare and look at the similarities between the two, and also contrast the underlying physiology and what that and the pathobiology and what that means for the clinical course of these two conditions, and also the differing treatment options and the differing responses to treatment for these two conditions. So the two airflow limitation conditions that we're talking about, as I'm sure you would know already, is asthma versus COPD. So we'll start with asthma, and that might be something that some of you have already had a personal experience, either yourselves or people that you know very well. So this is a chronic inflammatory disorder of the airways. Sometimes it can exist on its own, but frequently it's associated with atopy, so Hay fever or eczema are associated conditions that are immune-driven. And it frequently involves chronic inflammation. That may or may not mean chronic symptoms or persistent symptoms, but certainly chronic inflammation is measurable in a lot of patients with asthma. And the hallmark of asthma is airway hyperresponsiveness, and we'll discuss how that translates to pathophysiology and also clinical presentation soon. So the main symptoms for anyone who has even had a passing contact with asthma, you'll know that the main symptom is wheeze and associated shortness of breath. And this is a result of a fairly diffuse airflow limitation or airflow obstruction throughout the airways in the lung. So this slide you certainly don't need to know the intricate details of, but it highlights that this actually has quite a number of biological and cell-mediated pathways that result in a few different pathophysiological manifestations of asthma, and these are the things that we then need to be considering in terms of targeting treatment for asthma. So we can see here, if I just use the mouse as the pointer, this can be produced by a number of cell pathways, particularly the mast cell is the main immune cell, and that's the one that's most frequently associated with atopy, allergy and hay fever, and it's also the one that's associated with anaphylaxis, in fact, as well. So this releases a number of mediators that then stimulate other cells in the inflammatory cascade. The end results we can see down the bottom of the slide, and probably the two commonest manifestations are mucus hypersecretion, which we'll see shortly, and also bronchoconstriction, which is a combination both of hypertrophy, so increased smooth muscle mass, but also smooth muscle stimulation, so contraction. In chronic asthma, you can in fact get subepithelial fibrosis as well, though that's a very uncommon, that's usually only occurs in people who've had long-standing, poorly controlled asthma. So this is a couple of histological specimens that illustrate the pathophysiology of asthma quite well. So on the left, obviously, is the normal airway, and we can see the epithelium here with ciliated surface, and this is the airway lumen at the top. And then under the basement membrane here, there's a reasonable depth of subepithelial mucosal tissue, which appears very different in the chronic asthmatic airway. So there's a number of things that are illustrated here. The first is goblet cell hyperplasia or metaplasia in the epithelial lining, and that then obviously translates to mucus hypersecretion and cough for a number of people with chronic asthma. There's also a lot of subepithelial collagen deposition in people with chronic asthma, and this is the fibrosis that I mentioned on the previous slide. The other main thing is smooth muscle hypertrophy. So you can see here a very significant smooth muscle volume, and this smooth muscle not only is increased in size, it then also is much more prone to stimulation or hyper-responsiveness in patients with asthma. So this translates to a number of clinical consequences, and the most obvious is acute inflammation or acute hyperreactivity, and that's probably the commonest way that asthma presents in patients in the clinic, and they will present with symptoms relating to bronchoconstriction, so tightness, breathlessness and wheeze. And then this can sort of overflow into persistent inflammation, and this leaves people at more risk of exacerbations, which I'll discuss in a little bit more detail later. Very few people then have the further sort of overlap of airway remodelling, which is a result of the subepithelial fibrotic changes that can occur, and that's something that generally only is seen in people who've had poorly controlled asthma for several years. So it's easy to see on the next slide why narrowed airways cause symptoms, and this relates to Poiseuille's law of flow through a tube. So if we reduce the diameter or the radius of a tube, so in this case obviously the airway, then resistance to airflow goes up by a factor of 4 in relation to shortening of the radius of the lumen. So when we start off with slightly narrowed airways from asthma, that can be contributed to by smooth muscle hyperplasia and hypertrophy, but also epithelial and subepithelial edema, as well as mucus secretion. So all of those things leave asthmatic airways at a baseline narrower lumen, but then as airway smooth muscle contracts from the modestly increased resistance at the basal level, as that already narrowed airway contracts further and more prominently with smooth muscle hypertrophy, you can see the airway resistance markedly goes up for a given level of airway smooth muscle shortening. And we can measure this in the clinic, and I suspect you've already seen plenty of respiratory function tests in your time. So we measure this by airflow obstruction through looking at the FEV1, or the forced expiratory volume in 1 second, which I presume is not a new concept to you. Is that right? Nods, good. So this is one way that the spirometry can be presented. We'll see the more common way in a couple of slides' time. But we can see that forced vital capacity FEV1 generally is about 70% or more of forced vital capacity, and this would be fairly normal. You're able to expel most of your vital capacity within the first second of forced exhalation. For people with significant airflow obstruction, then the resistance to airflow is greater, the airflow is lower, and so it takes a longer time to expel the forced vital capacity. And here the FVC is only 30-something% of the FEV1 is only 30-something% of FVC, and that's quite a typical flattening of the expiratory curve. And this is not necessarily describing asthma, this is describing airflow obstruction. So the biggest reason that this causes breathlessness in patients is that the sensation of breathlessness is quite a complex one, in fact, but really it's something that's perceived in the brain, and it's when there's an imbalance between what the brain thinks the amount of work should be done to achieve a certain amount of ventilation and what it's actually needing to do to meet your ventilatory requirements. So you can imagine if you go for a quick 500 or 100 metre sprint, at the end of it you're breathing quite hard, but the sensation of breathlessness is very different to if you were breathing that hard sitting at rest. And obviously when you've run 100 metres, you know why you're breathless. You don't have that sense of anxiety and alarm. Whereas if you are that breathless sitting at rest, the brain knows that something is very significantly wrong. And so the way you perceive that breathlessness is very different. The other way you can induce this in yourselves is to put a resistive band around your chest, or even just a belt around your chest. And so to take a big breath requires much more work. Your chest wall is stiffer. And so that then is perceived as breathlessness, because you're still doing the same amount of, you're still achieving the same amount of ventilation, but you're having to do a lot more work to achieve that given ventilation. So asthma is really common. Again, probably 1 in 6 children, depending on what study you read, 1 in 10 and perhaps 1 in 20 adults have active asthma. So that's a big issue, and particularly for kids and younger people, there's a lot of impact on school and work attendance. So it not only has a significant disease burden, but has quite an economic burden and social burden for a lot of these people. Most asthma is exacerbated by the first 2 points on this list. So an exacerbation essentially is a transient worsening of symptoms from baseline. There are about 10% of people with asthma who have exercise-induced asthma, and the other factors listed there are fairly uncommon, though obviously if something like pollution is a significant issue, for an individual person it might be unlikely that their asthma is related to pollution, but at a community or a population level, as the pollution gets worse, then there'll be a significant impact on a large number of people with perhaps mild asthma that will then start to manifest more significantly in a clinical sense. It is the clinical setting that allows us to make a diagnosis of asthma, and of course there's a number of causes for wheeze. There's most obviously COPD is an alternative cause for airway obstruction, but it's the clinical presentation that tells us about the diagnosis of asthma, and that usually is acute onset wheeze and breathlessness, but significant day-to-day variability, and possibly with the presence of an obviously identified trigger for asthma. The other key for asthma is we certainly need to demonstrate airflow obstruction one way or another, and particularly, most commonly, we also like to see reversibility of that airway obstruction. And as I'll come to later, the biologic pathways that lead to airflow obstruction in asthma are generally viewed as being reversible. So if we can demonstrate that, then we are demonstrating findings highly suggestive of asthma. The demonstration of airflow obstruction is generally done with the FEV via the FEV1. So respiratory function tests, or particularly spirometry, and this can be both direct, where we're actually looking to irritate or stimulate the already irritable airways, and that either with histamine or methacholine, which target the effector, which irritate the effector cells in the airways, or it can be indirect bronchoprovocation, either exercise or hypertonic saline. And this provokes different pathways, not directly at the immune effector cells. So this is a reasonably typical respiratory function test of someone with asthma. And I guess I'll give you 10 seconds to just try and interpret the numbers yourselves. The first number that we would ordinarily look at is the FVC, forced vital capacity, and we can see that that's normal, so that we know that we are not dealing with a restrictive ventilatory defect. So the FVC is normal, and now next we would look at the FEV1, and we can see that that's moderately reduced at 59% of the predicted value for this person's gender and height. And the other measure that we would look at then is not just the absolute value of the FEV1, but the FEV1 to FVC ratio, which is 60%, which again is moderately reduced. The other typical finding on this, again, hopefully this is not new to you, is the flow volume loop. So you can see although the height of the FEV, the initial expiratory phase on the top of the flow volume loop here is pretty good, reaches a normal level. There's quite a significant scalloping of the remainder of the expiratory flow loop, which is very typical of small airways disease. Now, there's one other finding that is significantly suggestive of asthma in this report. Anyone want to suggest or have a think about what it is, and anyone want to shout out? So the biggest thing is that we've got both a pre-bronchodilator test as well as a post-bronchodilator test. And we can see that from pre-bronchodilator, where there was significant airflow obstruction, following bronchodilator administration, the FEV1 actually returns to normal. Importantly, although there's obviously significant obstruction pre-bronchodilator, and it does improve, the FEV1 to FVC is now 60% compared to 50%, there still is airflow obstruction present. So whilst the FEV1 is normal, the ratio of FEV1 to FVC is less than 70%, so we would say that there still is mild airflow obstruction apparent on this respiratory function testing post-bronchodilator. So there is reversible airflow obstruction, which is the hallmark of asthma, as we mentioned. So the common approach to assessment of asthma, or to thinking about how asthma manifests, is that there's by and large two components: smooth muscle hypertrophy and hyperresponsiveness, and these are addressed differently. So smooth muscle hyperresponsiveness or smooth muscle contraction is addressed with beta agonists, salbutamol, salmeterol, formoterol. And inflammation, which induces not just some of those changes that we looked at on the histological slide earlier, but also is responsible for airway hyperresponsiveness as well. Inflammatory changes can be addressed often very effectively with glucocorticoid therapy. And as you know, this is almost exclusively in asthma, given as inhaled corticosteroid therapy. Before the advent of glucocorticosteroids in an inhaled form, asthma was a much larger problem in terms of hospital presentations. And in intensive care units, there was frequently at least one person having a life-threatening asthma attack. But thankfully now to inhaled corticosteroids, most asthma can be well controlled in the community, and deaths from asthma are very rare these days. So asthma treatment is more than pharmacotherapy. I probably should have written asthma management is more than pharmacotherapy, because inside asthma management we would also include an action plan, things like avoidance of identification and avoidance of triggers, critically smoking cessation, and a problem that is hopefully less common these days is parental smoking for kids with asthma, so avoidance of secondary smoke exposure. But pharmacotherapy for people with active disease is pretty universally recommended. And the medication is, as we've already alluded to, designed to identify the underlying pathophysiology. So beta agonists for short-term symptom relief, but in fact sole use of beta agonists is actually a really bad idea in asthma, and in fact there are black box warnings both in America and in Australia strongly recommending against the use of beta agonist therapy only in asthma. And the reason for that is that can mask significant asthma activity, and increased, rare but increased deaths have been associated with sole use of beta agonists. The absolute centre point for care of asthmatic patients is inhaled corticosteroids, and most asthma patients will get away with just inhaled corticosteroids, and that is very effective at reducing the eosinophil and mast cell predominant inflammation that is present in asthmatic patients. So it reduces chronic inflammatory changes, but importantly it reduces acute or day-to-day airway hyperreactivity, which is usually, if there's low degree of airway hyperreactivity, then the likelihood of significant and severe exacerbations is markedly reduced, and I'll discuss that a little bit later again as well. Generally, oral corticosteroids are only recommended for times of acute exacerbation. There are very rarely people who have steroid-dependent asthma, so they have significant asthma symptoms despite high-dose inhaled corticosteroid therapy. Those patients usually are identified as having complicated asthma, and there's often some sociologic issues such as persistent smoking that are driving that, but very rarely they have very difficult asthma, and that's where some of the newer biologic agents are used for management of people with steroid-dependent asthma. And I understand that you're getting a lecture specifically on that topic in the coming days. For patients with persistent symptoms just on low-dose inhaled corticosteroids, the next step is generally to add in a long-acting beta agonist. And that's because the studies have indicated that people do better in terms of symptom control and in terms of subsequent exacerbation rate when they are given low-dose inhaled corticosteroids plus long-acting beta agonists, as opposed to escalating the inhaled corticosteroid dose. Very rarely these days leukotriene receptor antagonists such as montelukast are used. And then there are recent biologic agents targeting the IgE pathway in asthma. The reason that high-dose inhaled corticosteroids is not as effective as long-acting beta agonist in combination with low-dose inhaled corticosteroids largely relates to the dose response and the toxicity response curve of inhaled corticosteroids. So generally patients will be given about 400, as a low dose, about 400 micrograms of fluticasone equivalent. So about this point on the curve, and you can see that most of the therapeutic effect in terms of controlling airway inflammation and in terms of controlling bronchoconstriction is achieved at that point. as you go higher, you don't tend to achieve much more in terms of airway inflammation control, but you certainly do increase side effects. The commonest side effects from inhaled corticosteroids would be a hoarse throat. Sometimes people can get oral thrush, and there is a very low, but certainly not zero, incidence of increased lower respiratory tract infections, particularly pneumonia associated with high-dose inhaled corticosteroids. So the main focus of, so there's sort of a treatment pyramid, I guess, or clinical severity pyramid in asthma that we can potentially consider. And these two at the bottom are probably on the same level, in fact, because we can measure the progress of this, the remodelling and disease activity. We measure this clinically by looking at, in the clinic, asking patients how often are they experiencing asthma symptoms. And if we can control particularly the days that people have to use a short-acting beta agonist as a reliever, and the number of nights that people wake up due to symptoms of asthma, either breathlessness, but typically nocturnal asthma is cough, presents as dry cough. So if people are using beta agonists as a short-term reliever more than twice a week, or if they're being woken from sleep due to asthma more than twice a week, then the risk of them having a significant exacerbation, either moderate or severe, requiring hospital admission is markedly higher. So this is a really neat and easy way to see if we're on target with the effectiveness of patients' asthma control. So if we change direction now, we can look at a different condition that has significant pathophysiological similar pathophysiological manifestations, but very significantly different pathobiology. We can talk about COPD. So this is a much more heterogeneous group of disorders, and I guess you can possibly even guess at that because we've described it as obstructive pulmonary disease, which is a pretty broad umbrella term. Most of it is divided, as I'm sure you know, into chronic bronchitis or central airways related disease and emphysema. So those are the two conditions that will be present in people with COPD to varying extents. Some people have very bronchitis predominant disease, some people have isolated emphysema with negligible bronchitic symptoms. So it's a progressive and largely irreversible disease due to airway injury, and I guess you could argue whether it's an abnormal inflammatory response. In fact, you could also argue that it's a normal inflammatory response because most of this is in response to inhaled noxious agents. So COPD is a pretty big deal in a societal and in an economic sense. So it's the third leading cause of disease burden, which essentially is cost to society, ahead of heart disease and stroke. It's a very significant cause of mortality in Australia. If we look at this last point here, only COPD is continuing to rise in terms of cause of death. So this is since the 1960s, essentially due to sort of improved healthcare and improved primary prevention. A lot of these conditions, the death rate from most cardiovascular diseases is still falling, but COPD is increasing. There is some hope that this will start to turn in the future because the smoking rates amongst males in Australia peaked in about the late 1980s and has continued to fall since then, and although the smoking rate in females continues to rise. So there has been some slight drop-off in lung cancer incidence per 100,000 people, which is attributable to the reduction in smoking activity. Hopefully in time we'll see the same thing in COPD, but certainly in the developed world where smoking rates are continuing to, developing world, where smoking rates are continuing to increase, COPD is going to remain a very major issue for decades to come. So it's clearly under-recognised, in the clinic, so people can have mild to even moderate symptoms and either not report them, or their doctors will not recognise that these symptoms may well be related to COPD, and that's been established in multiple studies in the US, Australia and the UK. again, surveillance or examination of treatment practices, particularly at a community or GP level, suggests that COPD is frequently undertreated. And so there is a significant chance to improve health outcomes in this group through improved treatment approaches. It's impossible to talk about COPD without talking about smoking, because really in first world countries this is almost exclusively a smoking-related disorder. So anywhere from 20 to 50% of smokers will develop COPD in their lifetime. And certainly in the developing world there are biofuels, so sort of indoor pollution that can contribute to COPD, not generally an issue in Australia. Perhaps some studies suggest women are more predisposed to COPD than men for a given smoking history, but what's also clear is that there is a number of genetic influences that can affect the people's likelihood of developing COPD, again, for a given smoke exposure. And that's probably more important than the sex of anyone who is smoking. So the inflammation is in response to the inhaled noxious substances that are in cigarette smoke, and this does two things. There is injury to the small airways, which is much more neutrophilic in nature, as opposed to asthma, which is eosinophilic and mast cell based. So neutrophilic inflammation is much more injurious, and also the injuries that occur are much less likely to be reversed, even once you remove the noxious agent. The other thing that can happen is in response to airway injury, a lot of the inflammatory cells release proteases that result in injury and destruction of alveolar tissue or parenchymal lung tissue. So this does two things. You get the airway narrowing and the airway wall thickening that we saw, similar to what occurs in asthma, but what you also get is a loss of elastic recoil of the lung, and this essentially is the architecture that supports the airway. So I've got a stylised diagram on the next slide. Beyond about the 7th or 8th order airway division, remembering that there's about 23 airway divisions before you get to the alveolar space. Beyond about the 7th, 8th, maybe 9th order airways, there is not the cartilaginous structures maintaining the airway lumen. So those airways are dependent on the elastic recoil of lung tissue, which essentially is the tissue that pulls the lung tissue wants to contract because it's been stretched slightly to sit in its native state, and that holds airways open. So if you remove that supporting lung architecture, the airways start to collapse shut, and that is part of what contributes to airway narrowing and airflow obstruction. It's also a critical contributor to gas trapping in COPD, which is a much greater feature of COPD than it is in asthma. Gas trapping or hyperinflation. So we've already sort of discussed that there are different biologic pathways leading to the end result of airflow limitation. So mast cells, eosinophils, are highly steroid responsive, and the inflammation that they induce generally is highly reversible. So the airflow limitation that results in asthma is generally reversible, whereas the neutrophilic inflammation and certainly the destruction of parenchymal lung tissue is irreversible. And so we see that the airflow limitation is firstly irreversible, and secondly it's also, as we describe it, it's fixed airflow obstruction. So on the respiratory function test that we saw several slides back for asthma, we saw that there was significant improvement in the FEV1 and in the degree of obstruction following bronchodilator administration. We would not see that in COPD. There are some COPD patients that have a COPD asthma overlap that can demonstrate some response to bronchodilators, but generally they have a very incomplete response. They have only a modest and incomplete recovery of airflow obstruction. So we generally consider COPD to be irreversible airflow limitation. So because of the injury that you get with that you get resulting from smoking exposure, there's a number of different pathways that are triggered. One of the biggest issues is the mucociliary dysfunction, so you get cilia paralysis essentially. You get the structural changes that I talked about with parenchymal lung destruction. The other thing that you get that is not seen in asthma is systemic inflammation, and a lot of the spillover from a lot of the cardiovascular risk attributable to smoking is thought to be related to systemic inflammation. Certainly, if you all remember the fires at the Latrobe coal plant a year or two ago, there was a very marked increase in airborne pollution, and that community suffered a very measurable, very significant increased rate of cardiac adverse events, so ischemic heart disease events in the subsequent 3 or 4 months related to systemic inflammation resulting from airborne pollution. And people who have COPD have an increased degree of systemic cytokine and systemic inflammation that can be measured, and that's part of the risk, and those people have a higher risk of, patients with COPD have a higher risk of cardiac disease relative to patients without COPD who have the same smoking history, and it's thought probably that the systemic inflammation that occurs in COPD is likely responsible for that. So it's a significant limiter in terms of people's quality of life from day to day when they're well. They have reduced exertional capacity, they can't do the things that they want to do basically, but in terms of an economic burden, the biggest issue is exacerbations of COPD, and these are periods of transient significant worsening in lung function and often in symptomatology, both breathlessness but also frequently cough and heavy sputum production. So this obviously reduces their physical well-being. There's significant impacts on their mental well-being. People have markedly reduced level of function for up to 3 months after their exacerbations. They have an exacerbation and either are managed in the community or in hospital. During that exacerbation, they often experience not just the breathlessness-related reduction in functional performance, but they often have significant muscle wasting and then increased frailty for some time after an exacerbation. People who are frequent exacerbators also have an observable, markedly increased rate in the decline of their lung function from year to year. And so one of the main aims of reducing exacerbation rate in COPD patients is that we not only are protecting them for the next few months in reducing their exacerbation risk, but probably more importantly, protecting them for years and years in terms of protecting their lung function. So exacerbations, often when we see them, certainly in the clinic and certainly in the hospitals, can be due to either bacteria, viruses or airborne irritants. Usually when we see people in hospital, it's presumed that they have a viral exacerbation, but if people have a significant systemic illness and particularly significant increased sputum production or increased sputum purulence, we assume probably that there's a bacterial component to their exacerbation as well. So most people will be treated with a combination of oral corticosteroids for their exacerbation and probably antibiotics for presumed bacterial component. It's difficult to assess exactly what the contribution of bacteria is because depending on the severity of COPD, 1/3 and probably even 2/3 of patients will grow bacteria in their sputum. And so most people who have a productive cough, which is the definition of bronchitis essentially, most of those patients will have bacteria that you can grow from their sputum, and that's most commonly Haemophilus influenzae. Whether it's certainly a colonising agent, but when people are clinically well, we just continue to view it as a colonising agent. So the diagnosis of COPD is probably similar to asthma in that we want to see a consistent clinical picture. So this is someone who almost certainly will have smoked for decades, probably, and they will usually have increasing exertional dyspnea. By the time they talk to a doctor about it, it's probably been present for over a year or more. So slowly progressive exertional dyspnea. Often they will have slowly persistent cough as well. Usually they have daily cough, although the definition of chronic bronchitis is daily cough for 3 months of the year, which most commonly is over winter. But most often when we meet them, they do have daily cough throughout the year. There are other risk factors, but these are generally fine print, I would say. It's really all about smoking, but marijuana certainly accelerates parenchymal COPD. You tend not to get so much chronic bronchitis, but you can get very young onset. So by young, I mean in your 40s. Young onset in people who've had heavy marijuana use. Alpha-1 antitrypsin, as you probably know, is genetically inherited autosomal recessive disorder, and alpha-1 antitrypsin is a protein that switches off the proteases in the lung, which occur normally, and so you essentially get protease-driven parenchymal lung destruction. So alpha-1 antitrypsin patients tend to have emphysema predominant or emphysema exclusive COPD, I guess highlighting the fact that chronic bronchitis is largely smoking related. And so the difficulty is that COPD, we do consider it an irreversible condition, but that doesn't mean that we're not very keen to offer treatment to these patients. The most critical thing is smoking cessation by a long, long way for people who still smoke. But in fact, when we meet people with COPD, at least 50% are ex-smokers, and obviously they feel a little bit ripped off when they turn up with a smoking-related diagnosis, having quit 10, maybe even 20 years ago. But that's now because there are more ex-smokers around than current smokers. It's still common to see people who've quit smoking and who now present with a diagnosis of COPD. So this is a stylised diagram, and a majority of people follow this schema, but certainly it's recognised that not everyone does. But for the majority of people, when we hit about 25 years of age, from that point onwards, we tend to lose about 30 mils per year in our FEV1. That's just a normal part of ageing. And so most people will lose 30 mils in FEV1 and never notice it. We're born with about 3 times as much lung capacity as we can ever use. Even elite athletes are only limited by their cardiac output. And so you have to have quite significant lung disease for your lungs to be the limiting factor in your exercise capacity. So most people never get there. If you smoke through your 20s and 30s perhaps and stop before the age of 40, then you will almost certainly not have symptoms related in other exceptional circumstances notwithstanding. You'll very likely not have symptoms related to lung disease, because although you've lost lung in the earlier part of your smoking life, your rate of decline in lung function will very likely return to approximately the normal amount. But for people who continue smoking throughout their years, they will eventually reach a point through more rapid FEV1 decline where they actually experience exercise limitation due to breathlessness. Now, you remember I said earlier only about 20 to 50% of smokers will get this, so this is not the curve that all smokers will follow, but certainly a significant proportion will. So for people who do smoke, there's not much value in doing anything else apart from, or not much value, but certainly the focus is on smoking cessation, because that's far and away the most protective thing. So non-pharmacologic supports, so counselling, advice, guilt trips, all have some effect, but when we see people in the clinic who are persistent smokers, we are very keen first up to offer them pharmacologic therapy, and that's because the likelihood of maintaining abstinence out to 12 months is markedly higher. So the likelihood of staying abstinent is in single figures percentage at 12 months if people just decide to do it by willpower alone. For the studies have indicated that for people who use varenicline, that number might be as high as 50%. So for that reason, we would ordinarily recommend to people that they use pharmacological support for the early part of their quit attempt. In COPD, beta agonists are used similar to asthma, so largely for acute wheeze and symptom response. Long-acting beta agonists are a mainstay of treatment of COPD. So we would, as opposed to asthma, where inhaled corticosteroids are the cornerstone of treatment, inhaled corticosteroids have much less value in COPD, and it's long-acting bronchodilators that are the key to symptom control and even exacerbation control. So long-acting beta agonists such as salmeterol would be one of the first things prescribed. Anticholinergics are probably actually in fact the first line treatment for people with mild disease-causing exertional dyspnea. And these are probably the most effective single agents in COPD. So improve exercise tolerance. They actually are recognised to improve exacerbation rate as well. And this is a bit difficult to understand. Why would a muscarinic agonist, a bronchodilator cause reduced exacerbations? But in fact, there's some basic science evidence to say that there is paracrine crosstalk between smooth muscle and also smooth muscle, which is where obviously the muscarinic agents act, and the airway epithelium as well. Inhaled corticosteroids are much less effective because of the difference in pathobiology of the inflammation. So being neutrophil predominant inflammation, inhaled corticosteroids only achieve a very little amount. And in fact, it's isolated to people who have severe airflow obstruction and who frequently exacerbate. So if patients are not in that group, then they're likely to do worse with inhaled corticosteroids. And that relates to the increased rate of lower respiratory tract infection secondary to high-dose steroids. It does need to be high-dose steroids, and it should only be used in the severe COPD group with frequent exacerbations. There are a group of patients who have severe airflow obstruction but do not experience frequent exacerbations, and that group should not receive inhaled corticosteroids. Similar to asthma, it's been recognised that combination therapy is useful, and there's actually recent studies indicating that triple therapy, so inhaled corticosteroids plus a long-acting beta agonist and a long-acting muscarinic agonist antagonist are more effective in people with significant persistent symptoms. There are a number of other things very infrequently used, but these are for very troublesome patients. So theophylline is a very old drug and has very limited evidence supporting its use in improving muscle function in severe COPD, so reducing perceived dyspnea. Roflumilast is generally limited again only to people with severe COPD and frequent exacerbations. There's a lot of conflicting evidence for long-term antibiotics. These do get used on a not particularly predictable basis in the clinic for people who have chronic bronchitis generally and frequent exacerbations. The other ones are the next few are the non-pharmacologic therapies. So pulmonary rehabilitation certainly will improve patients' functional performance and reduce their perceived dyspnea and may reduce exacerbations in some studies. Vaccinations, these people are not really more at risk of influenza, but certainly more at risk of severe consequences of influenza and also pneumonia. Long-term oxygen therapy is generally only used for patients with baseline severe hypoxia. And the reason that actually has a mortality benefit in patients with severe COPD, and the reason for that is that once people have a partial oxygen pressure below 55 or 60 millimetres of mercury, they actually develop pulmonary vasoconstriction, and this can lead to pulmonary hypertension. So there is a mortality benefit in oxygen at preventing progression of patients to have pulmonary hypertension. This pulmonary hypertension would generally result in something called cor pulmonale, which is a bit of a historic disease. We don't tend to see it much these days because of long-term oxygen therapy. And I won't discuss lung volume reduction, but it rarely gets performed. So in conclusion, there is a significant burden in the population of conditions resulting in airflow limitation, but the two commonest ones are in fact very different diseases. And as a result of that, treatments that target inflammation in asthma do not necessarily work in COPD for the reasons we've discussed. There are novel therapies particularly for asthma, but certainly there's a lot of a need for newer therapies in COPD, which I suspect at this moment is still quite a long way away. Thanks very much for listening. Happy to take any questions now or on the way out if that's easier. Great, thanks guys.
It's terrific.
Oh, good. Does it?
That's me. Oh, awkward.